Hi, let's
Hi.
go.
Okay, so we still have 4 minutes until the official start time. So we'll wait for 4 minutes to start the session so more participants can join us.
Okay. So Eunice, we want to start just on time. We start just on time.
Yes.
6. Okay.
We still have 3 minutes.
Okay.
Mm.
So 6 p.m. I start. So
Yes.
opening. Okay.
Yes, yes, please. Thank you. GI. So we would like to welcome Professor Yasushi Sano to give us an opening remarks. Thank you,
Okay.
Professor Sano.
All right. Hello, guys. So I'm Dr. Sano from Kobe, Japan. And I think that everyone is having a hard time, I think, with spreading of COVID-19 infection all over the world. So I just prayed for your health. And so I'm going to start the webinar tonight entitled the ANBIG Clinical Case Marathon 2021, session 10, Polypectomy and EMR for lower GI. As you know, the large intestine is an organ with many neoplastic lesions and sedated lesion by colonoscopy examinations. And it has been reported that adenoma detection rate and post-colonoscopy colorectal cancer is closely related. So therefore, endoscopists, we required to remove the many colorectal tumors efficiently and reliably with accurate diagnosis by the colonoscopy. So today's case conference, so we gonna focus on the such point and discuss such point. And tonight we are inviting 4 famous doctors, Professor Kim from South Korea, and Professor Shen from Australia, and Professor Kamura from Japan, and Professor Kim of South Korea as a guest pathologist. So the Professor Kim, please start your keynote lecture.
Okay. Okay, do you see my slide? Yes. Okay, so I will start keynote lecture about colon polypectomy and EMR techniques. Actually, I have only 10 minutes, so my talk is mainly about the recent published studies in relation to current guidelines of colon polypectomy and EMR. So our recent meta-analysis reported 14 cases of the incomplete resection rate on the margin assessment after colon polypectomy. Considering the incomplete resection rate, the region differentiation for selection of the optimal procedure is very important and essential. To differentiate treatment indications, we have predicted cervical invasive cancer using several endoscopic findings. And regarding morphology, the region with ulceration and the hardness or the large nodule or with converging fold and with central depression or the chicken skins are known as highly suspicious region of cervical invasive cancer. And P-pattern examination using chroma endoscopy provides significant findings in determining a treatment strategy. P-pattern type 3S and 3L, 4, and slightly 5 patterns can be removed by endoscopic resection. Image-enhanced endoscopy such as ANBIG is the easiest way to observe regions. The Japanese ANBIG expert in classification improved the accuracy of endoscopic treatment indication with more detailed sub-classification of the region. Genotype 2A regions can be confidently performed colon polypectomy and EMR, and if the region is observed as type 2B, we have to carefully select a region with additional process for endoscopic resection. Regarding techniques, the current procedures we daily perform in the clinical practice are as follows: the cold forceps polypectomy and cold snare, hot snare, or EMR, or piecemeal pre-cut, TBIN, and underworld TMR, except for hot forceps polypectomy. This is a European guideline published 4 years ago, and this is the USA, the Multi-Society Task Force guideline last year published. Comparing the two guidelines, there is no significant difference in the optimal procedure depending on the polyp size and morphology. The cold snare polypectomy for removal of small and diminutive polyp, and EMR for large and pedunculated polyp are very simple. So what is your choice of procedure for removal of diminutive polyp? This is an Asian multinational survey study recently published. In this study, the most preferred technique for removal of diminutive polyp was cold forceps polypectomy. Actually, CFP is an easy way to remove a diminutive polyp, but standard size CFP showed a considerable incomplete resection rate even in the polyp larger than 3 millimeters. The jumbo forceps increased the complete resection rate for removal of diminutive polyp regardless of polyp size. As shown in a recent meta-analysis, the incomplete resection rate of a CFP with standard size forceps was more than twice that of snare resection in the removal of diminutive polyp. And another recent study, a recent meta-analysis study, showed no difference of the complete resection rate between jumbo forceps and cold snare polypectomy regarding diminutive polyp removal. Therefore, the current guidelines suggest that CSP is the basic procedure for removing diminutive polyp, but jumbo forceps polypectomy is also available for polyp less than 3 millimeters in size. Regarding small polyp removal, cold snare polypectomy is a standard technique in both guidelines. It is already known in several meta-analysis studies that CSP has no significant difference in the complete resection rate compared to hot snare polypectomy. And regarding complication, although there was no significant difference between the two procedures in the meta-analysis, but the safety of CSP, especially in delayed breathing, that clinicians fear is superior to hot snare polypectomy. And residual adenoma rates after CSP were acceptable, reported as ranged from 1 to 2.5% in recent prospective studies. And also, CSP with injection, cold EMR method showed no difference of complete resection rate in the removal of a small polyp compared to conventional hot EMR showed over 90%. However, the CSP excises the region shallower than Snare polypectomy. The submucosal layer contained in the excised tissue by CSP was significantly lower than that of Snare polypectomy. In addition, this recent study reported that more than 50% of the CSP cases were improperly excised for a pathological analysis. And this recent retrospective study showed that when a protrusion defect occurs during CSP, this increases the risk of fragmentation of a specimen while increasing the risk of incomplete resection and lowering the accuracy of a pathologic diagnosis. Because CSP resected region shallow and specimen damage can occur during the procedure, the region discrimination with magnified MBI before the procedure was reported as a way to increase the R0 resection. Above all, the endoscopist experience was also an essential factor in reducing the incomplete resection rate of CSP. Although Snare polypectomy and EMR are the main procedure for endoscopic resection of large polyp, cold snare resection or cold EMR are the treatment options for large regions without SM invasion in the USA guideline. Actually, cold resection method is not suitable for embryo resection of large regions. According to a recent study of a cold EMR for large adenoma 10 to 14 millimilli, the embryo resection rate was about 83%, and histologic complete resection rate was only 64%. In the removal of large adenoma, piecemeal cold EMR showed high recurrence rate, and the recurrence rate increased significantly as the polyp size increased. In addition, a recent systematic review showed the recurrence rate of cold snare resection as 11% in the removal of 10 to 20 millimeter size of adenoma, and over 20% for adenomas rather than 2 cm. However, the recurrence rate was only 1% in removing the large sessile serrated adenomas. In fact, cold piecemeal EMR has shown outstanding results for removal of large sessile serrated regions in recent studies. This study showed 0.6% of a residual rate in the surveillance colonoscopy after removal of large SSLs with cold piecemeal EMR, and cold EPMR was more advantageous in recurrence than conventional piecemeal EMR for SSLs rather than 20 millimeter in another study. Also, recent Japanese study reported 0% of a recurrence rate after removing large SSL with piecemeal cold snare polypectomy without an injection method. Therefore, in removing large SSLs, cold resection method, including cold EMR, has the advantage of being easy, safe, and having a low recurrence rate, showing the potential as a standard technique. Recently, this interesting study compared the cost effectiveness of cold EMR and hot EMR in large sessile polyp. When considering the intervention for complication during the procedure and additional treatment for recurrence, cold EMR was a more cost-effective strategy compared with hot EMR for removal of large sessile polyp. And this difference was largely driven by the absence of necessity for a routine prophylactic clip closure with cold EMR. Regarding advanced EMR techniques, T-beam EMR, the anchoring EMR, has advantage of increasing the embryo resection rate for large non-lifting flap region with no increase of adverse event in a recent randomized trial. And underwater EMR showed a lower recurrence rate and the incomplete resection rate for removal of large polyps than conventional EMR in a recent meta-analysis. Summarizing the recently published studies about polypectomy and EMR, the cold resection technique are continuously expanding the indications for benign regions without a submucosal invasion, especially in consideration of safety and cost effectiveness. However, as several studies show, the shallow resection and high rate of improper excision for pathologic analysis of the cold resection techniques, the region differentiation for invasiveness before the procedure is very important step. Okay, this is my keynote lecture. I just briefly talk about the recent published studies about colon polypectomy and EMR. And so now let's move on to case presentation. And we have 4 wonderful cases today by Dr. Kawamura and Professor Sen. I hope all of you enjoy the cases and think about the region differentiation for invasive region and indication of procedure for each case. Dr. Takuji Kawamura from the Kyoto Second Red Cross Hospital, Japan, will present the first case. Dr. Kawamura, are you ready?
Okay, thank you, Professor Kim. I will show you 2 cases in the colonic polyps. So I will show you the first slide. Okay. Can you see the slides?
Yes, very well.
So this is my first case. So this region was located in the descending colon, and the small region in the screening colonoscopy, and we find the redness in the descending colon. So this is indigo carmine staining, and this is the slightly closed the view. So my first question, what is this morphology of this region according to the Paris classification? So 1S, 2A, 2B, 2C, 3, or 1. This is not a neoplasia, that's just erosion.
Okay, I can see the now voting, and yes, 76 to 60% the attendance chose the type 2C.
Okay, thank you. So my diagnosis was the type 2C. Okay, the half of the attendees answered the 2C. Thank you. So we show the next slide. Sorry. So this is the NBI findings. The 2 slides of the NBI, and this is the NBI with magnification. So okay, the next question, what is the genetic classification? The type 1, type 2A, 2B, type 3. So
wow, it's changing. Yes, 40% chose the type 2A, and 55 or 60% chose the type 2B.
Okay, so thank you. So many participants understand this is not type 1 and not type 3. This is slightly difficult to differentiate type 2A, type 2B in this region. So I'm sorry, the Professor Sano, what is your opinion?
Yes, in this finding, I think regarding a bezel future, as you see, each bezel is not demarcate each pit surface pattern. Some bezel showing some irregularity. The direction is several direction. And surface pattern, but I can still identify some tubular-like, but this surface pattern is slightly irregular. So that in the genetic classification, this finding is classified as 2B.
Thank you. So, as the Dr. Sano mentioned, my diagnosis was genotype 2B. I think in this region, the surface pattern is not clear. So we diagnosed by basic pattern, the variable carrier and irregular distribution, and this is genotype 2B. The next slide. So this is we performed the crystal violet staining, and so this is the crystal violet staining with magnification. So what is the bit pattern? The classification, the type 3S, 3L, 4, 5Y, or 5N.
Okay. Okay, type 4 and type 5I each 40%.
Yes.
Yes.
So I'm sorry, but again, the Professor Sano, what is your opinion? Sorry, Professor Sano, the mic.
Yes. In this findings, upper side of this flat region showing combined with type 1 and type 3L pits. So, but this area, so very small pits, and maybe staining is not so clear. But I think this is a smaller pit compared than here. This is a type 1 pit, but this pit is smaller than compared than surround normal pits. But this area, I think slightly irregular pits can be seen. So that I think this area 3S, lower some parts is 3S, and some parts very tiny areas type 5I, and upper side is so 3L was type 1.
Yes, thank you. So as Dr. Sano said, our diagnosis was type 3S. Because in the depressed area, the not irregularity is not high. However, the pit pattern was the very small pit and smaller pit than the the lab area. So we diagnosed 3S. But as Dr. Sun said, some doctor says that this is 5I. So, but my diagnosis was type 3S. So let's move on the next slide. So what is the next step? We diagnosed the type 3S, but the diagnosis was not invasive cancer, but we diagnosed the mucosal cancer. So what is your next step?
Okay, now we are voting.
Yes.
Yes, but please join the vote because we have 110 participation, but only half of the join the vote, and 30% chosen the ESD, and 25% the pre-cutting EMR, the hybrid ESD, and 30% also chose the conventional EMR, and 16% chose the underwater EMR.
Yes.
Yes.
Yes, I think the important thing is that this region should be performed unblocked resection, so that if you can resect by unblocked resection, that you can choose the conventional EMR or underwater EMR. However, we choose the conventional. We don't choose the conventional EMR because sometimes the piece rejection will be performed. So we choose the pre-cutting EMR or the hybrid ESD. So we cut around the region and slightly dissected during the submucosa, and the next the snaring was performed. So the umbilical resection was performed. So this is a rejected specimen. So this region was well differentiated adenocarcinoma with no submucosal invasion. In Japan, we diagnosed this region as the mucosal cancer. So the final diagnosis was cancer with adenoma. We were differentiated that carcinoma, the pathological TIS, the no vascular invasion, the margin negative. Thank you for your attention.
Okay, thank you for the excellent case. And Professor Sano, do you have any comment or question for this case? And we are now waiting the question or comment on the chatting the note.
I think Professor Yong Hee Kim, she also prepared some slides regarding this case. Shall we ask Professor Kim, would you like to share it now or after the Q&A discussion?
After the second case.
After the second case, okay.
Okay.
Yes.
No problem.
Okay. So why, just one question from here, from the audience. So why did you choose the hybrid technique? So do you have any explanation about that?
Thank you for your question.
Yes.
So if this region was larger than 2 centimeters, we will perform the ESD. However, fortunately, this region is very small. This region might be 1 centimeter. Mm-hmm. So we can choose the EMR hybrid technique hybrid technique to perform the umbilical rejection. So we don't use the ESD, but the hybrid ESD or the pre-cutting EMR. Okay.
Sorry, so what kind of device you used?
In this case, we choose the dual knife or the dual knife. Then, however, recently we can choose the hybrid ESD device, and Solten device. However, in this case, we choose the dual knife.
Okay. Because I think dual knife is very expensive in Japan even. So hybrid, Solten knife is it's a special knife for the hybrid EMR. So it's very cost is very cheap. I think 1/3 of compared than dual knife. So that I asked.
Yes,
thank you.
I completely agree. In this case, we performed 4 or 5 years ago. So in this case, the Solten device cannot be used in our hospital. So we use the journal.
Okay, here another question about the case. Because the size was only 10 millimeters, so a conventional EMR is still okay. The audience thinks. So, what is your opinion?
Yes, if you can perform if you have the confidence of the umbilical rejection, so you can choose the conventional EMR. However, sometimes we cannot perform the umbilical rejection by conventional EMR like this, the depressed region. So we choose the hybrid.
Okay. So I have one question about the diagnosis code. So because the intramucosal cancer
Yes.
was not used in the Western area, and actually the universal term is PTIS cancer. And in Japan, so the pathology is reported like this: the well-differentiated adenoma with intramucosal cancer. What will you choose the diagnosis code? I mean, the C cancer code or the D01, the carcinoma in situ code?
Sorry, what is called?
How do you treat the surveillance about this case? Cancer or just the CIS?
Yeah. If the margin was negative, we usually perform the 1 year's later in follow up. If this is not cancer but adenoma, we usually perform the 3 years of the EMR. However, about the like this region, when mucosal cancer, we perform the 1 year later.
1 year.
1 year.
Okay. Let's see. So, Professor Sano, do you have any comment or any question?
No, I'm okay. Thank you very much. Wonderful.
Okay, so let's move on to next case. Okay.
Okay. So. Okay. Can you see this right? The next case. This case, this region was located in the cecum. So about 25 millimeters in the protruded region in cecum. And sorry. So what is the morphology? The classification. The 1S, 2A, 2B, 2C3, type 1. Okay. So what is your opinion?
Okay, please vote about your opinion. Okay, so much. I just one question about the voting. Just only I can see the voting result, or everybody can see the voting result?
Everyone can see the voting result when we end the polling and share the result.
Okay.
So after it's done, then everybody can see the result.
So I see. Okay, the 50% chose the 1S type, and 21% chose the type 1 advanced cancer. Okay.
So thank you. As for the surface pattern, we diagnose this is not invasive, not advanced cancer. So we diagnose the morphology. The morphology is type 1S. Okay. So the next, this is the NBI, and this is the underwater NBI with the magnification. So what is the genetic classification in this case? Okay.
Yes, please vote the genetic classification. Mainly about the regular pattern, I think. Okay, the 63% chose the type 2A, but almost 30% chose type 2B.
Yeah, thank you. So I think this is slightly difficult to differentiate type 2A and type 2B. So, but I think the irregularity of the surface pattern was not so high. So we diagnosed this surface pattern with type 2A. Okay. So the next, we performed the staining. So this is with magnification. So what is the pit pattern magnification? So,
Please both about the P pattern. Okay, similar rate for type 3 and type 4.
yes, I think type 3L and type 4 is both the correct. The some part is type 3L and some part in type 4. But I don't think this is a type 5. So we diagnose this is a mother's region. So but in the previous hospital, this region was the with non-lifting sign. So they recommended the surgery. So, however, the patient want to receive by endoscopic procedure. So we performed by the endoscopic resection. So what is what is the next step? The conventional EMR and what the EMR, pre-cutting EMR, ESD, or the surgery is recommended.
Yes. So Dr. Kawamura, I have a question.
Yes.
So what is your what is your the considerable thing is before the procedure selection, the region location, or I mean that this region is located in the cecum area, and the previous hospital showed the unlifting sign. So how you I wonder about that makes not easy to select the endoscopic treatment or the surgery, I think. Yes.
The tutor approach the biopsy was performed in the previous hospital. However, the biopsy results was not cancer.
Yes, right.
So this is only adenoma. So we try to perform the endoscopic procedure. However, as you know, the cecum region is very high risk of perforation or post-EVSD coagulation syndrome.
The voting results show the 43% chose the ESD method.
Yes.
And, underwater and conventional EMR is a similar 20%. Yes.
So this is the non-lifting sign positive. So we discussed that this region, the ESD was the risky for this region. So we choose the underwater EMR in this region. So next. So this is
Can I ask a question?
Okay.
Yes, go ahead.
It's a very nice case. Can I ask Professor Kamamura what is the? It's very important to look at where the appendix is in this instance as well.
Yes.
And the relationship of the polyp to the appendicular orifice.
Sorry, and thank you for your question. So the appendicular orifice is slightly in the apart from the region. So appendicular orifice is next to this region. So this is the not so close. About the 5 or 10 millimeters apart from this region. Okay.
So if the region was located in the appendix orifice, is there any difference the choice of your procedure?
Okay, if the appendicular orifice is not clear, perhaps we choose the surgery.
Surgery, yes. Yeah. So you perform successfully underwater EMR, right?
Yes.
Very good.
So as the complete resection was achieved, and yeah, can you see this movie? No. Okay. So Professor Kim, can you see the movie?
Yes, I can see the movie very well. Yes.
Oh, okay.
Yeah, interesting. Please go ahead. Yes.
Okay.
Professor Sano, do you have any comment or question about the case?
So why the in this case, I think this is located at the bottom of the cecum, so and Villus future, so that I think I often experience such as non-lifting sign in the Villus tumor at the located cecum. I think it's due to the severe fibrosis is occurring in the submucosa, usually in bottom of the cecum. Sometimes the cessa-insulated lesion is occurring in the cecum bottom. Such lesion also the fibrosis is often occur. So maybe due to some I don't know bile juice or I don't know the reason why, but yeah, this case is yeah sometimes I experience.
So what is your choice, Professor Sano, for this case? If you were,
maybe I, if possible, I additionally perform the EUS.
Yes.
Yes, and confirm the submucosal layer invasion. But anyway, the surface pattern is still preserved as type 4, so that I perform the ESD or underwater EMR. I agree this strategy.
Okay, here is the question from the audience. Will the snare tip coagulation of the margin help in this case?
Yeah, unfortunately, we try to perform the envelope resection. However, I'm afraid of the operation, so the resection depth was slightly shallow. So the small amount region was the remained. So we performed the slightly piecemeal resection. But the most of the region was rejected by envelope. So I'm sorry. What was the question from audience?
The snare tip coagulation of the margin.
Snare
tip coagulation on the margin.
Snare tip coagulation. We usually don't perform the snare coagulation. Perhaps many Japanese endoscopists don't perform the snare tip coagulation.
Yes.
So, yes.
Because here is the cecum area, and the cecum wall is very thin, and just a question about will the snare tip coagulation of the margin will help to this case for prevention of the recurrence?
Yes. However, we perform the NBY with magnification, and we check the endoscopic resection ulcer. So we usually don't perform the snare tip coagulation after the resection.
So how's the pathologic report?
Yes, yeah, thank you. This is the pathology. The surface of the region was the villus adenoma. However, in the deep of the region was the cancer, and the slightly invasive into the submucosa. So the final diagnosis was cancer in adenoma, and were differentiated the adenocarcinoma, the pathologicality 1 day, and the mucosal invasion depth was 200 micrometers, right? And vascular invasion was negative. Thank you for your attention.
Okay. Professor Sano, do you have any comment?
In this case, fortunately, the depth of invasion is only 200, and Professor Kamura's diagnosis is correct. But I think so. Some villus tumor, prediction of the depth of invasion is very difficult by the magnified endoscopy, because villus tumor, the surface is preserved, but the most worst histology is occurring in the bottom of the villus tumor, and sometimes invasive such a cancerous cells transform to the mucinous carcinoma and invade to some mucosa. So endoscopically villus future, but sometimes such region invade to some mucosa deeper. So that anyway, so unblocked resection or deeper resection is very important to resect unblock. Yes, this one, such a villus tumor.
Okay, so the question from the audience: what's the opinion for underwater EMR? Or experts. So the underwater EMR is commonly used in the Japan.
Yeah, not so commonly used. But however, in my cancer area, the underwater EMR is performed in many hospitals.
Yes.
However, in the not so widely spread in even in Japan.
And so, what were the setting, the ESU, the electrical surgical unit for this underwater resection? Is it?
Yeah, setting is the same as the conventional EMR.
Conventional EMR, same with that. Okay. So, okay, the Professor Yoni Kim, do you have any comment the case, or I was told that you have some brief presentation about the cases.
Yes, just a moment.
Okay.
Thank you for inviting me. I got one question in previous meeting, so I prepared this slide. I hope true understanding for pathology in colon. According to WHO classification 5th, conventional adenoma meaning is benign premalignant neoplasm. It's composed of dysplastic epithelium. This meaning is normal mucosa changed to benign precursor. This epithelium is composed of enlarged and hyperchromatic nuclei. It also shows varying degrees of nuclear spindling and stratification, and also polarity. So, grading of adenoma is composed of two tiers. High grade meaning is marked complex glandular crowding and irregularity, and cribriform architecture, and intraluminal necrosis. And intramucosal carcinoma meaning of ACE, AJCC show involvement of lamina propria without muscularis mucosa and no penetrating muscularis mucosa. And T1 meaning is invasive mucosa. I have two cases. One patient reveals two polyps. One focus and his epithelium is normal and crypt architecture and goblet cells. This person is also shows crypt architecture cylinder, but increased nuclear. So this diagnosis is low-grade adenoma. Second focus reveals a variety change of epithelium. This focus will be normal, and this area reveals low grade, and this focus will be high grade, and this one is cancer. More high power view, this could be a normal gallbladder cells, and this nuclei is enlarged and spindled. So this epithelium is low grade, and this shows more specified, and this shows in cribriform architecture. So this result is high grade. This focus normal and low grade. This one is high grade, and more complexity shows cancer focus. At high power view, a nuclei is different. This one is normal and more enlarged, and this one shows increased mitotic activity and nucleoli and more pleomorphism. So diagnosis is low grade, normal, and cancer focus. The result is one focus is low grade, and this one focus will be intramucosal carcinoma. Second case is similar to previous second case. This also shows a polypoid lesion. This epithelium is normal, and this focus will be low grade, and this shows more complexity. So this could be a high grade portion, and this area reveals more severe complexity. So this focus will be a intramucosal portion. And this cytologic ATPR reveals more increased nuclei and increased pleomorphism. So this focus will be intramucosal carcinoma. So we do immunohistochemistry for cytokeratin for epithelium and invasive focus. And this one is specimen for evaluating the muscularis mucosa. Tumor cells do not penetrate the muscularis mucosa. So this diagnosis is intramucosal carcinoma. So normal, low grade, high grade, this focus will be intramucosal carcinoma. This slide is first case at low point. This one is normal colonic mucosa, and these thin pinkish materials will be muscularis mucosa. And this one is increased nuclei, so it could be low grade adenoma. And I didn't have any high power view. I think this focus will be high intramucosal carcinoma focus, but these cells do not penetrate this muscularis mucosa. So the diagnosis of this case will be intramucosal carcinoma. And this focus will be low grade. This one is intramucosal carcinoma. And second case reveals this focus will be normal epithelium. This one is low grade adenoma. And this focus reveals more complexity, so more than high grade adenoma. And it shows also angulated gland beneath this muscularis mucosa. So this cells reveals invasive focus beneath the muscularis mucosa. So this one is adenocarcinoma in submucosa. Do you have any questions?
Okay, thank you for good comment and lessons about pathology. So it is very helpful to understand the pathologic report. And so Dr. Kawamura or the Professor Sano, do you have any comment?
No, thank you very much. Your very nice presentation.
Okay, so so we have thank you, Professor Yanni Kim, for kind the lessons. So and we have to move on to the next case from Professor Sin. And the next case presentation will be by Professor Sin from the University of Adelaide, Australia. You ready?
Yes, thank you. I'll just share my slides. Is that visible?
Yes.
Oh, thank you. So firstly, I'd like to thank the ANBIG group led by Professor Sano for this kind invitation. I also like to thank Professor Kim Yong-hee and Professor Kim Gun-hyun for this forum, as well as Professor Kawamura, and of course Eunice and Joanne in the background. So we have nicely covered underwater EMR and hybrid ESD. So I think my talk will concentrate on other techniques of EMR. So this is case 1, and this is a lesion which is seen in the colon. As you can see, it's granular in nature. I'm not going to go so much into advanced mucosal imaging because that is a subtopic for a different day. But I'd like to ask the audience as to what would they do for that lesion. So these are the options. You biopsy and refer to surgery, do a cold snare EMR, hot snare EMR, a full thickness resection, or would you do an ESD?
Yes, please vote. As you can see, the hot snare EMR and ESD are a similar rate for chosen.
Yes.
Yes, cold snare EMR is 9%.
9%. Very
Yes.
good. So what about you, Professor Kim? What would you do?
So actually, I'll do just the EMR, hot snare EMR.
Okay.
Yes.
And Professor Sano?
Me too. I performed the standard EMR, hot EMR.
Okay. I'm gonna show what may be an option, something called a cold snare EMR, and I'm gonna take you through some of the indications for this. So we know that the audience equally chose hot snare EMR and ESD, so I just get rid of the polling. So careful selection is important when we want to attempt cold snare EMR, and I'll show you why. It's ideal for sessile serrated lesions, as Professor Kim showed in his presentation. But there's more data coming out now for lesions which are flat, especially if they've got a Paris type 2A granular type morphology. And obviously, it's very, very important, just as in most cases, to rule out submucosal invasion, and that's where advanced mucosal imaging comes into play. So I'll go through why cold snare EMR. So our conventional thinking with hot snare EMR is that we need the current to cut underneath or through the polyp. All right, we have more assurance that we are doing it the right way because we also think that we will probably kill any microscopic tissue or adenoma. And of course, our present thinking is that with the hot current, we will seal vessels to prevent bleeding. And a lot of times, we kind of do it because we simply know that we are used to it. We've been doing hot snaring for 15, 20 years for some of us, and we think perhaps that is the way to go. But is heat really needed to cut through tissue? It's not always, because deeper tissue that it's really not necessary to get if the polyp is non-malignant. Okay, so this is a slide which was also shown by Professor Kim, and you can see that hot snare polypectomy and cold snare polypectomy, the depth of cutting through at least to the muscularis mucosa level is almost similar. So we're not talking about malignant polyps, but you can see it's 96 versus 92%. So the depth of cutting underneath the polyp, if the polyp comes from the epithelium, is similar with both techniques. Now, we also think that hot kills microscopic tissue, and this is a study which was performed 8 years ago, which shows quite a high recurrence rate of 27% with hot snare. And of course, we need a margin of normal tissue between the snare and the edge of the polyp. And we still must avoid leaving tissue at the base of the polyp. So hot snare does not necessarily do the job. So we also think that hot prevents bleeding. Yes, for immediate bleeding, definitely, but not for delayed bleeding. Now, these are just some of the studies which we have used hot snare EMR coming from the Australian colonoscopy EMR group, for which we were involved with as well. And we have shown that there is a risk of clinically significant delayed bleeding, especially if the lesion gets larger and it's in the right side of the colon. So then we kind of think, so what do we get with cautery? We obviously get a risk of delayed bleeding. I didn't touch on this, but there's an elevated risk of perforation or post-polypectomy syndrome. But on the contrary, when we use hot current, obviously we can get en bloc resection rates like what Professor Kawamura has shown with that villus adenoma in the cecum. And we may get en bloc resection rates of polyps up to 2 centimeter in size as well with the hot current. So cold snare polypectomy for lesions more than 10 millimeters, this is a systematic review and pool analysis which has been done a couple of years ago, which shows that this is fairly effective for sessile serrated polyps in this study with very, very low intraprocedural bleeding, in fact non-existent, and delayed bleeding of 0%, recurrence rate of about 4%. So these are just some of the techniques which I'll go through. We need to inject when we do a cold snare EMR, but the purpose is not to protect the deep muscle layer because we're not using current, but the idea is to loosen the submucosa. Now, obviously, we can sometimes use a bit of adrenaline or epinephrine to reduce venous oozing during resection, and we have to use some stains because this helps to define the border of the lesion. So an injection is slowly and carefully put, as you can see there, carefully lifting obviously the stain there, and what we then use is a smaller, thinner, stiffer snare is ideal, and these are some of the snares which are available. They are specialty snares, dedicated cold snares which can do the job, and they're generally smaller than the normal snares which we use, ranging from 9 to 15 millimeters. Don't show the tail of the snare. If you show the tail of the snare, as in this case, what will happen is the snare will tip up and down and make the resection very difficult. The idea is to push down and advance the sheet as the snare is closing and to cut small pieces, taking a rim of the normal mucosa, as you can see here in this earlier slide I showed. We take a rim of the normal mucosa, and then we progress sequentially and cut this lesion. Start from one edge and then overlap, and then we just repeat the sequence, and this can be done fairly quickly. This is just an example of another lesion, which is obviously a tubular villus adenoma. I won't go through the details, but you can actually see the patterns over there, which is very nicely shown. This is just sort of imaging using the underwater technique. So the lesion is carefully first injected in one edge, and then once we lift, we put a snare down carefully, and then we start cutting sequentially. Now again, this lesion is not a malignant lesion. All we need to do is to get underneath the polyp to cut it in a sequential manner. and the resection can be done fairly quickly and swiftly. This whole resection probably took a few minutes to do. Now you can see that as we are moving towards one edge to the other, we're just gonna cut in small pieces, and obviously the lesion is gonna move away towards the most dependent or gravitational area. Now, if you're not happy with one edge, you can evaluate it. We've got very good scopes these days, which enables us to look at things and carefully place the snare at one edge to get that remnant polyp, and then just slice it off like that. So as we move sequentially, you can get fairly good results as you would see towards the end here, where the lesion has been resected. And if you're unsure of certain areas and you want to sort of take off little divots, like in this case, you can do that as well if there are certain islands which are missed. So this whole process actually took probably about 3 or 4 minutes to do, and it's very effective taking off lesions such as this, as you can see there. So that is the end result, which was a fairly good result for the patient, and the risk of perforation and delayed bleeding is 0%. So some things which we need to know about troubleshooting is don't take too much pieces, limit the size of individual resection pieces, and if you're stuck and it won't cut, wait for probably about 20 seconds to 30 seconds as the snare may transect the polyp. And if you're still stuck, you can straighten the scope, deangulate and detorque, and straighten the sheet of the catheter to cut further. Of course, if you continue to be stuck, then you can loose the snare slightly and deflect away from the base and then close again. All right. Sometimes if both techniques fail, then you can let go of the tissue and cut it in 2 separate pieces. So you may have a stump or stalk of submucosal tissue hanging out like that. So don't be worried about it, because that is generally a bit of sometimes even muscularis mucosa sticking out from the base. The cold snare is very, very useful for antiplatelets or patients who are antiplatelets or on anticoagulants. I will guide you to this review article, which was published last year, to have more information on that. And we can also use this outside the colon. This is in the duodenum, extending over probably about 3 folds tubular villus adenoma, which was easily dealt with using the cold snare EMR technique. And we can also tackle fibrosis, this lesion which has been dealt with multiple times by others. And you can see a thick fibrotic area there. And this was slowly sort of resected carefully without any cautery. So this lesion actually is in the duodenum. Given the higher risk of bleeding, we did not use any cautery and carefully resected it in a piecemeal fashion. And slowly placing the snare and carefully taking bits of the lesion out and sucking it into the channel. It's just using the so-called RDI technique, where you can see that the base is clear. It was fairly sort of a tough polyp, which has been cleared off. So even fibrotic areas can be dealt with using this technique. So there's no stress without cautery. We can get quicker as you are more comfortable with this, and potentially can be accessible to more endoscopies. And you really don't need prophylactic clips, like Professor Kim has said in his presentation on cost effectiveness. So it is possibly no limit with flat lesions. I'll just quickly go through hot EMR, because these are important for bulkier sessile lesions which are suspicious for submucosal invasion, especially if we can resect in a single piece, like what Professor Kamamura showed earlier, and previously tackled lesions as well, and sometimes fibrotic lesions. So the technique is similar. This is just, since it's a polypectomy talk, I'm just going to show you, this is over a few folds, maybe 3 or 4 folds in the colon, a lesion which was deemed to be suitable for hot EMR technique. We're slowly injecting and resecting in a sequential piecemeal sort of fashion. And you can get fairly good results at the end, as you would see here, where the whole lesion has been resected using this wide field EMR technique, almost 30 to 70 to 75% of the circumference, as you can see there. And we can need to prevent recurrence, and somebody spoke about the snare tip soft coagulation method, and this is how it's done when the resection is performed. Again, this is from one of the studies which we were involved with. You apply the snare tip soft coagulation to the edges, and the risk of recurrence increases dramatically. These are for lesions which are more than 20 millimeters in size, up to about 4%, which is a good result. These days, our recurrence rates are less than 1% as we get better and better with this technique. So I'll put case 2 now. This is 82-year-old gentleman.
Okay, Professor Sim, just
yes,
have to check about the comment or the questions from the audience. Or
yeah.
Professor Sano, do you have a comment about this case?
So I think yeah, I agree. I can understand why you performed the so-called piecemeal cord dissection. So do you have any tips to retrieve all the specimens by the EPMR?
It's a very good idea. So what we tend to do is a lot of the times, because the resection of these polyp remnants are fairly thin and small, they can actually be sucked through the channel with the snare inside the channel itself. Occasionally that doesn't get through, and towards the end of the resection, we can remove the snare and then just suck everything through.
Oh, okay.
So a lot of times, because they're thinner than the hot snare EMR technique, mainly because they are generally SSL type lesions, so they just suck through the side of the snare sheet.
Thank you.
Okay. So there's no question or comment from the audience. So okay, we have limited time. So let's move on to next case.
Okay, thank you, Professor Kim. So we have done hot snare, we've done cold snare, we have done underwater EMR, and we have done hybrid ESD. So I'll put in this case of an 82-year-old man with multiple comorbidities, ischemic heart disease, has had CABG performed or bypass surgery, multiple stents more recently, and is not an ideal surgical candidate. Has iron deficiency anemia and had a colonoscopy, and this was what was found. So this is in the ascending colon. What would you do? Would you biopsy or refer to surgery? Again, would you do a cold snare EMR, hot snare EMR, a full thickness resection, or an ESD?
Okay, to please to vote about the question, what would you do? So, Professor Sim?
Yes.
The question for the previous case from the audience, can we use cold EMR for colonic residual or recurrence, especially in the right colon?
It is possible. Having said that, sometimes there is a lot of issues with fibrosis underlying the tissue, and there may be difficulty in resecting the tissue. The snares are thin wire snares, so sometimes it does cut through these tissues, but occasionally it doesn't.
Okay, so vote results reveals the ESD is 30% and others are a similar rate. Cold snare EMR, hot EMR, full thickness resection was chosen 24%.
Okay, what would you and Professor Sano do? What are your thoughts on this case?
So I think so. Take a look at this lesion. It's a depressive type lesion, so that so demarcation line is very clear. The surface I maybe this is a destroyed in Janet type 3 or 9-3. So I think yes, yeah, these findings usually Japanese endoscopists recommend surgical resection of course, we performed some EUS or some other procedure, but I think mostly our Japanese endoscopists recommend the surgical treatment. How do you think, Kamura Sensei?
Yes, I agree with Professor Sano. This region is a depressed region, and in this depressed area, the fruit well demarcated in the area, and in the central of the region, the genetic type 3. So we diagnose this region as the submucosal cancer. So we recommend surgery for this region.
Mm-hmm.
And Professor Kim, what are your thoughts?
Yes, actually, I agree with the Professor Sano and Dr. Kawamura, but I do performing the radiologic test before the procedure selection for surgery or the performing ESD like that.
Yes.
Mm-hmm.
So the patient's CT scans were clear. Unfortunately, the patient is not a surgical candidate because of multiple comorbidities. We don't have any anesthetists on the forum, so they were very scared of the patient having a complication during surgery. So we decided to perform a full thickness resection. So this is just a short video of another patient where they had what looked like a perforation on a previous resection, which was clipped, and the patient came back later on for this sort of scarred-like tissue, heavily scarred. And somebody was asking whether cold snare would help in this case. Certainly it won't, because it's just stuck and pinned down to the wall. So what we then did was we did this procedure called a full thickness resection, where the lesion was captured with a large forceps carefully into a cap. And then what is done is a clip, or what's called as a bear claw clip, is placed across the lesion, and then a snare is used to cut the lesion above the bear claw, as you can see here in this cartoon. And this is the end result you get for that lesion. They've got very good technical success rate, but obviously 75% complete resection rate. So not 100%, not fantastic, but sometimes for some patients without much options, this could be the way to go. So for this patient, we did just that. Obviously it's an advanced polyp. It's definitely a submucosally invasive cancer, and this was tackled with this device. You can see the forceps, which is quite large, but you can see visibility is really very difficult, mainly because the cap is actually quite long, and hence maneuvering past the left colon can sometimes be very, very risky and difficult to do. So that lesion was pulled in, and the back claw was used to sort of cut through it. Sometimes we can also use this full thickness resection device for polyps within a diverticulum. You can see this here. So this is an example of a polyp which actually has extended into the diverticulum, best seen on narrowband imaging and using the underwater technique. It would be very difficult to get into the diverticulum using any means, EMR or ESD. In fact, it would be dangerous. So in this instance, what we did was we did the full thickness resection. We marked that area, because it's very difficult to see once the cap is there. So you can actually now see that the cap was put, the forceps was used to pull through, and then we go and snap it shut, and then we come back to reassess things, and you can see obviously a bit of serosa there as well. So sometimes for scarred lesions, we can use this technique. Sometimes for lesions with superficial submucosal cancer, or patients who are poor surgical candidates, and occasionally lesions which are extending into the appendicular orifice. Having said that, risk of appendicitis is about 14% in those patients. So I just end with this for complex polyps. All right, so we know that for polyps which are 20 millimeters or less, we can use cold snare techniques. We can also use hot snare techniques if they're more bulky or sessile. But sometimes we also have to consider, not only for complex polyps, but for all polyps, safety, anticoagulation, antiplatelet therapy. The bowel preparation needs to be good to perfect. Some things we can modify, like reposition the patient or retroflexing in the right colon or in the rectum. But some things are unmodifiable, like polyps extending into the IC valve, appendicular orifice polyps, or polyps which are on the dentate line. So we have to take time to look at that. We have to also plan for it, right? 10 minutes per centimeter size of polyp, and add more time if we need to retroflex. Obviously, you need to have equipment and support from other specialty staff, because you can have complications. If you are unable to do it, though, there's no harm in seeking a second opinion. It can be endoscopically resectable, possibly, but just not by myself. Maybe someone like Professor Asano or Professor Kawamura in Japan. So you take photos and send it off to a more experienced endoscopist. You may want to biopsy 1 to 2 superficial biopsies of the most abnormal area and tattoo distal to the lesion at least 2 folds. But if the lesion is in the cecum or rectum, that's not necessary. So this is summary slide. I would say for polypectomies, cold snare EMR can be used mostly for sessile serrated polyps. Avoid protuberant depressed lesions or suspicious of SMI, which we covered briefly today. You can also look at, there's more data coming out for tubular adenomas and tubular villus adenomas. Hot EMR is capable of addressing most of the other lesions and prevent recurrence with the snare tip soft coagulation method. Obviously, we did not discuss ESD because that's part of another clinical case marathon session. But with FDR, careful case selection is necessary. So thank you very much.
Okay, thank you for your wonderful case presentation. So, Professor Sano, do you have any comment or question about the second case?
Okay, so I have no questions. So excellent. Thank you very much.
Okay, so just one question from the audience. How is the risk of ovescal detachment after full thickness resection?
Yes, so the success rate for technical success rate is about 83%, as you saw, and the histological success rate is about 75%. So 3 in 4 chance you'll get it right, 1 in 4 you won't. So that is something you have to be careful of as well. There are other complications, as I said. Sometimes moving the scope with the ovesco clip through the left colon with a lot of diverticulosis can be a big problem. So you have to be careful with that also. And when you're putting the clip onto the tip of the scope, make sure you don't deploy the clip on your finger, because that will be very painful.
Mm-hmm. Okay, thank you. Thank you for good answers. And one more question. What's the risk of operation with cold snare EMR? Maybe related with the first case?
Yes. As of now, there has been 1 case report of
Yes.
perforation with cold snare EMR. I personally have had 1, and we're trying to report it as well. So it can occur. The reason it occurs is because once a polyp is trapped in the snare, and if it's not cutting through, what we found is some people tend to yank or pull the snare very hard with a lot of force. And that can sometimes be dangerous because you may capture muscularis propria. Mm-hmm. So if the snare is not cutting, what you need to do is to release it carefully and try to sort of recapture it. If not, just cut that area in 2 pieces. But do not yank it with a lot of force, because when yanking, meaning pulling with a lot of force, can sometimes capture too much tissue underneath and can also lead to a perforation.
Okay, thank you. So time's up, and we'd like to close today's ANBIG case marathon session. And thank you for all participants to make a wonderful case presentation and also to make a good case discussion. And so special thanks to Professor Yeonhee Kim for pathological comment for this case marathon. And I hope to see all you again in next ANBIG case marathon. Take care of all of you in this hard COVID situation. And thank you.
Thank you.
Thank you very much.
Weekend. Yeah. Bye-bye.
Good night. Good night.
Thank you. Thank you to all.
Thank you very much.
Thank you.